Şimdi ben Sayın Paty'yi bu sefer de büyük tümörler, T4, N2, bulky tümörlerde beklegör tedavisi için bir aday olabilirler mi? Bunlar da bir seçenek midir? İsimli konuşmasını yapmak üzere davet ediyorum. Please.
Thank you, Professor Osoglu. Pleasure to be here. Salman, I enjoyed your talk. I think the answer is you prefer surgery. I'm going to talk at the other end of the spectrum about very large tumors and whether watch and wait is an appropriate option. This is a little bit easier topic because generally we radiate these tumors anyway. So as Gerard says, this is kind of a pick the winners scenario. If you get a great response, is it safe not to operate? That's the basic theme. And in thinking about this talk, in previous talks, and in my own experience, I think quantification of locally advanced disease is not trivial. MRI has been a huge advance in being able to show the tumor as it invades adjacent organs in some detail and giving us a better handle on lymph node spread. But still, I find the description of locally advanced disease in the literature very lacking. Usually it's just a T4 here and N2 there and with not a lot of details. So I think a lot of this is built on personal experience and judgment on a case-by-case basis. But locally advanced disease is generally thought of as T stage and N stage, but we also have the problem of obstruction, have the problem of fistula, and occult spread from, say, prior surgery, et cetera. And again, the published detail is somewhat lacking and non-granular, but I'll do my best. Again, risk stratification by MRI is terrific. This is the good, the bad, and the ugly paradigm, which is popular in Europe. I think it's a nice diagram. It's not very useful for what I do. We don't give short course radiation. If you don't have a treatment to match up with a category, it doesn't do you much good to have a category. So, but I do find all the details that you see on MRI very useful. It's an excellent roadmap for surgery, both in the presentation and in the assessment of response and planning surgery. So MRI is huge. Here's an example of a very large tumor invading the prostate and base of the bladder. And this is probably a little bit out of the realm of what can be controlled without surgery. But on the other hand, think about what we do to these patients with surgery. They certainly stand to benefit if we could intensify our therapy or direct it in such a way to avoid an operation. Here's an example of a total exoneration performed recently. Or vaginectomy with ureteral resection and reimplantation. These are quite big operations with significant complication risk. And nodal disease I find even more complex. I really find it extremely difficult to extend my understanding of nodal disease. This is a patient of mine who had an aggressive anal adenocarcinoma that presented in a very early stage. We treated by an excisional biopsy and refused further treatment. And 2 years later, he shows up with this and a rising CEA. And I'm fairly confident these were malignant lymph nodes in the mesentery and the pelvic sidewall. He was treated with Folfox, followed by chemoradiation, followed by APR and lymph node dissection. All these lymph nodes were sterile. Were they malignant? Were they inflammatory? Were they downsized by the tumor, or by the treatment, the adjuvant treatment? I think probably they were. They did shrink with treatment, but again, this is the difficulty in quantifying and measuring the impact of multimodality therapy in these cases. I think it's very difficult. And again, the consequences of extended lymphadenectomy, unlike the Japanese, in my patients, when they've been radiated, particularly if they have bulky tumors, nerve sparing is really not an option when you go to the lateral pelvis, I find. The nerves have to be removed in order to be thorough in a lateral pelvic dissection. So again, the consequence of this can be serious, although unilateral autonomic nerve preservation is usually sufficient for acceptable bladder function. So I'll just lead with my biases here. I think very clinical evaluation treatment of very large rectal cancers for a watch and wait strategy is very challenging. As Gerard pointed out, I think the literature shows pretty clearly in most neoadjuvant series that bulky tumors, larger tumors, advanced T-stage, advanced N-stage are predictors of incomplete response in general. That's fairly consistent. And again, I agree. I think it boils down to the volume of disease, especially in the primary tumor. With a large tumor, with a hypoxic core, with necrotic cancer there, that's failed, it's difficult to penetrate with chemotherapy, and it has more genetic heterogeneity within it as they get larger, are probably harder to cure without an operation. Furthermore, when these tumors respond, the assessment of response is difficult. Often it takes a longer time for these tumors to regress. They leave behind extensive fibrosis, which is very challenging to assess clinically. I think the MR data is compelling and interesting, but I don't make clinical decisions based on MR imaging strategy, very rarely, because too often I've seen the diffusion-weighted image and other predictors to be wrong. And I think clinical assessment followed when necessary by exam under anesthesia with deep biopsies when the tumor has achieved its maximal response is the only real way to get beyond clinical assessment. MR is helpful, it guides us, but it's not on its own compelling to me. So I'll just proceed from there. After giving these biases, I'll review some of the few reports in the literature, the limited data that's available. So we'll talk about first surgical resection of T4 cancers. What are the results? I'm going to focus on T4 disease because it's a little more clear than advanced nodal disease. And then we'll look at some of the neoadjuvant series, looking how often T4 tumors are included in those series and how many of them achieve a PCR in the surgical series. And then we'll look what's available in the watch and wait series. So this is a little out of date, but nothing's really changed. We reported our data for extended resection for T4 rectal cancer, see if this pointer works, in 2012. And I was thinking that since we use neoadjuvant therapy routinely for large tumors, I thought this would be maybe an addition to the literature that would say something different in that many of the other series from Japan in particular, where many of these are published, neoadjuvant therapy is not routinely used. They're often taking these people directly to the operating room. But I was somewhat surprised to find that when we compiled our data, our 5-year survival rate of 53% was right in the middle of what had been published before. And really, we had nothing particularly different to say than what had been published before, other than local recurrence rate was rather high. In our series of T3 cancers, our local failure rate treated with neoadjuvant therapy is under 5%, so 18% is a big number. So these are clinical T4 tumors treated by neoadjuvant therapy, mostly chemoradiation alone, some with total neoadjuvant therapy. And in our series, these are the organs resected. You can see by far vagina is the most common organ, and this is considered by the MRI staging criteria to be a rather low-risk T4 lesion, but I beg to differ. I think vaginal invasion is very dangerous. There's rapid lymphatic spread within the vagina, and if the tumor is invading the vagina, you must be very radical by taking out the vagina. You can have intravaginal recurrence, which I've seen many times. The uterus, the bladder, seminal vesicles, etc. So in our series, like every other series that's been published, the major predictor of outcome is R1 resection, or R0 status. And again, with an R1 microscopic margin, even in the setting of neoadjuvant therapy, there's a doubling of the, or lowering of the survival rate. But you can see, although our series wasn't large enough, that T stage and N stage, the final T and N stage after neoadjuvant therapy, so this is a surrogate for response to treatment, were also borderline significant and fairly significant predictors of 5-year survival. So let's move on and look at the broader neoadjuvant series. This is the multi-center analysis Gerard put together looking at the rates of PCR after neoadjuvant chemoradiation and TME. And this data has been shown before. This is the third time, I think, today, but you can see T-stage is a major predictor of pathologic CR and half the rate of smaller tumors. And this is pretty much uniformly observed. Here is another large series from Korea. Again, a very mainly stage 2 and stage 3 rectal cancers. And these were the variables on their multivariate analysis that emerged. CEA, interestingly, is a recurring theme in the literature, as Gerard mentioned, but again, I feel these are surrogates for a volume of disease also. But you can see using these 3 clinical predictors, you can come up with a scoring system that can stratify PCR fairly well in their series, with the larger tumors having a low rate of pathologic complete response. Another series from Canada, 260 patients, retrospective, T2 through T4. Again, not many, only 5% of patients here, 0 PCRs. Again, what was the neoadjuvant regimen? How long did they wait? Very hard to know if this is generalizable disease, but overall, again, advanced T-stage negative predictor. And again, in a setting where the overall pass-CR rate of 17% is fairly typical from the literature. So what can we say about intensifying neoadjuvant therapy? There's many different publications showing intensified chemoradiation and chemotherapy regimens in various orders, or intensifying the radiation dose. But here I'm showing Dr. Garcia Aguilar's study, the timing trial, where standard long course chemoradiation was given, and then sequential groups were followed with the standard approach and 2, 4, or 6 cycles of FOLFOX to follow. I'm sure many of you are familiar with this. You can see the clinical T-stage here is shown within each group. T4 tumors were a small minority in the range of 1% to 4%. So they probably didn't have a big impact on this trial, and the data for T4 weren't published, but you can see certainly that the intensity of the neoadjuvant therapy had a big effect on overall pass-CR rate, up to 38% with 6 cycles of FOLFOX. The neoadjuvant regimen was a major predictor of pass-CR, very powerful predictor, the biggest predictor in this study. And the clinical predictors were not very strong. And that may be because the tumors were rather homogeneous. There weren't that many T4 tumors to look at. Or maybe if you have a strong enough neoadjuvant regimen, the T-stage becomes more irrelevant. I don't really know. I don't know the data well enough. But in this series, clinical predictors were very weak. So what about watch and wait series? How often are T4 tumors included? These are largely numerator studies. We don't always have the exact denominator, but let's look at what's there in some of the larger series. In Dr. Habergama's 2014 publication, where they looked at, so I recall about 100 clinical CR cases, there was only one clinical T4 tumor in the lot, and that patient did experience local regrowth in their most recent published series. Maybe Gerard can enlighten us, but they, in the Netherlands series, have included T4 tumors, and it seems, the best I can tell, they've done pretty well. There have been no local regrowths. Again, they use a lot of MRI, highly selective in who is managed by watch and wait. Our own series, which I'm going to present tomorrow, which is an updated series, not from our clinical trial, but from our retrospective data of 113 clinical CRs. We had no clinical T4 tumors in the watch and wait group. And in the Manchester series published about a year ago, again, about 6%, and they did have 2 cases, I believe, of local regrowth of T4 tumors. So variable data, but at least we can say that T4 lesions are at least included in these studies. And nodal disease is much harder to capture. Again, I'm not quite sure. Most report just node positive versus node negative. There's not a great data to support that nodal disease as staged by MR has any impact on watch and wait. We know from the German trial and other prospective studies that neoadjuvant therapy has a profound impact on nodal disease, and I don't think there's really any data to say that nodal disease, at least nodal disease within the radiation field, is a contraindication to watch and wait. The results for local regrowth do not seem to be any worse for clinically node positive than clinically node negative tumors. Again, a figure from Dr. Habergamer's most recent publication, they looked at clinical predictors of complete response in their 90 complete responses versus a concurrent group of 93 non-responders. And basically, although there was a bit of a trend, there was no prediction by T-stage or end-stage as to who had a complete response. Looking at our own limited series, as I mentioned, in our watch and wait group, we had no T4 cases, probably because we're a little bit conservative in that regard. In the corresponding PCR group, which I'll be reporting tomorrow, there were 5 T4 tumors. All were resected and have been NED with a median 4-year follow-up. And as far as N2 disease, this is N2, again, within the pelvis, not N2 spreading up to the aorta or outside the pelvic radiation field, but for T2 tumors, the outcomes, or N2 tumors, the outcomes were excellent in the watch and wait group, no recurrences, no cancer deaths, and also in the resected group. So again, my bias achieving PASCR in a large bulky T4 tumor is difficult. You don't see many of these cases in watch and wait series. The assessment of response is more difficult, but can be done. Again, we haven't captured the extent of which these T4, and then there's T4 and there's T4. These are probably smaller T4 tumors, but there's very few cases, limited data, and we can only just say that T4 disease per se is not contraindicated. I will say, based on my experience, the tumors that are contraindicated or very difficult to manage by watch and wait are tumors that have primarily submucosal growth. And these are not that rare, at least in my practice. In the anal canal, the anal gland carcinomas are relatively high-grade mucinous tumors that tend to grow submucosally. The tumors associated with Crohn's disease are mucinous. They tend to grow submucosally. The high-grade tumors seen in ulcerative proctitis or ulcerative colitis tend to be signet ring type tumors. They grow intramurally. They're very hard to assess clinically, and I think very hard to judge the response to radiation, and they're also high-risk tumors. So this is an example of an anal mucinous adenocarcinoma. This is actually a lady who's refusing surgery right now. I'm following her. She's had a stable MR for 6 months. I've biopsied this mucin 3 times in clinic, and it's acellular. And she's asymptomatic, and we're watching her closely. And in this case, I think MR is very helpful. Once this tumor progresses on MR, she'll have a resection, and I hope it can still be completed. I like completed resection. Here's an example of a low rectal cancer rising in the setting of ulcerative colitis. What you may not, this man presented with obstructive symptoms, no other symptoms, no bleeding, and all of this tumor is submucosal. You look in, you see a nice smooth mucosa. This is all growing intramurally. Very difficult to assess response. He's in the middle of treatment now. He's had FOLFOX, now he's getting a radiation, and this was also a node-positive tumor. So these tumors, in my mind, are very difficult to manage. High-grade tumors, submucosal growth, highly infiltrated, those that are difficult to assess clinically and that present in an advanced stage. So what do we do with these T4 tumors? Anything special? Well, I think, again, this is a setting where, although I'm not a great proponent that MR is required for non-operative management, I've been doing this for 11 years, and my results with and without MR, as far as I can tell, are the same. Its clinical assessment is the key. And MR is supportive, but often wrong, I think, compared to good clinical assessment. But I think in these cases, frequent MR imaging, if you really have a patient who's motivated and you think is a candidate to avoid surgery, intensifying treatment is a possibility off protocol. We know there are ways to boost the pass CR rate with additional chemotherapy or intensifying radiation. And then with assessment for clinical CR, I completely agree with Gerard. I think this is a test of time. As long as the tumor is in a state of regression, clinical regression, there's no urgency to operate. And it's generally best to wait. And frequent clinical assessments, and then once you've reached a maximal response and the tumor's been stable for 3 or 4 months and you're still uncertain, I think there is value to take the patient to the operating room and do deep biopsies into the fibrous scar to look for cancer. Not perfect, but I think helpful. So in summary, T4 cancers represent about 3 to 10 or 12% or so of all rectal cancers. They're somewhat underrepresented in the watch and wait series. What we see in the literature is very limited description of these tumors. We don't know exactly how big they are, where they're invading, how they presented. There aren't many cases, and the details of these cases are very limited, but the available data does suggest that T4 tumors can achieve a PCR, can have successful outcomes, but I think caution is advised when treating these tumors by non-operative management. Thank you.